Okay, let's unpack this. Today, we're diving deep into a topic that touches countless lives and, for many, remains a bit of a medical mystery. Neuromuscular diseases.
Mhm.
When you hear about persistent weakness, maybe unexplained muscle pain or strange sensory changes, well, it could be pointing to a really vast and intricate group of conditions. They demand a truly precise understanding.
Absolutely. And what's fascinating here, I think, is how these seemingly straightforward symptoms, weakness, pain, can actually arise from problems at so many different, very specific points in our body's incredible communication network.
Right. It's not just one thing.
Not at all.
Yeah.
So our mission for this deep dive is really to guide you through this complex landscape. We'll explore the essential anatomy, look at the diverse ways these diseases show up, and importantly, their underlying causes, from inherited predispositions baked into our DNA to conditions we acquire later in life.
Yeah.
And we're going to break it down anatomically. We'll start with the peripheral nerves. Think of them as your body's wiring. Then we move to the neuromuscular junctions, these crucial communication hubs between nerve and muscle.
The connection point.
Exactly. And then into the skeletal muscles themselves, the engines, really. We'll even touch on the unique tumors that can grow along these pathways.
So the goal is to really get a handle on this, maybe master this information like the elite professionals in the field do. So you're not just informed, but actually insightful.
That's the idea. Think of it as getting that deeper perspective.
Consider this your shortcut, then, to being genuinely well-informed. Understanding not just what happens in these disorders, but the intricate why. So let's jump in and truly master this information together. Okay, so to really get our bearings, let's start with the basics. What exactly are neuromuscular diseases, and why are they considered such a, well, complex group in medicine?
Well, at their core, neuromuscular diseases typically announce their presence with a kind of triad of symptoms.
Yeah.
Weakness, muscle pain, or changes in sensation, tingling, numbness, that sort of thing.
Okay.
But what makes them complex isn't just those symptoms, it's really their origin and their diversity.
Yeah.
They can be inherited, passed down through families, or they can be acquired, developing later in life due to all sorts of factors.
Right.
So for physicians, these conditions represent an incredibly intricate diagnostic roadmap. They get grouped based on where the problem physically lies in that body communication network we talked about.
The anatomy.
Exactly, the anatomy. Also, how the disease progresses over time. Is it fast, slow, relapsing? And then the underlying cause, what we call pathogenesis.
So it's far from a simple blanket term. It sounds like it's a very precise way of categorizing what's going wrong. And our deep dive today has a specific anatomical focus, doesn't it? We're not just casting a super wide net.
Precisely. For our discussion today, we've carefully narrowed our focus down to 4 primary anatomical areas. Makes it more manageable, right?
Yeah.
First, we'll examine disorders that preferentially affect the peripheral nerves, which are basically the body's wiring system outside of the brain and spinal cord proper.
Okay, the wires.
Second, we'll move to that crucial communication point between nerve and muscle, the neuromuscular junction.
The bridge.
The bridge, yeah. Third, we'll explore diseases that directly impact the skeletal muscles themselves, the powerhouses of movement,
The engines.
the engines. And finally, we'll look at a distinctive category, peripheral nerve sheath tumors, which are abnormal growths that can pop up along these delicate nerve pathways.
Okay. And it's probably important to clarify what we won't be covering today, too. Because, similar symptoms can easily trick you into thinking you're dealing with the same kind of problem when you're not.
That is a very good point. We absolutely need to distinguish these peripheral issues from conditions that cause similar symptoms like weakness or numbness, but actually originate in the central nervous system, meaning the brain and the spinal cord itself.
Right, different origin.
Totally different origin. Those are distinct disorders, very important, of course, but they fall outside the scope of today's deep dive. Our focus is truly on the periphery, the wiring, the junctions, and the engines that connect out from the CNS.
All right, let's zoom in then on those peripheral nerves. Before we talk about what goes wrong, maybe we should quickly review their amazing structure and function. It's kind of like understanding the blueprint before diagnosing a problem with the house's electrical system.
Perfect analogy.
Oh.
Our peripheral nerves are incredibly sophisticated structures. At their most basic level, they consist of what you could call an impulse transmission duo.
Okay.
You've got the axons, which are the actual wires carrying the electrical signals, and then the myelin sheaths, which act as the insulation around these wires, much like the rubber coating on an electrical cord.
Right, protects it, speeds it up.
Exactly. And these myelin sheaths are meticulously crafted by specialized cells called Schwann cells. Now, any injury, whether it's to the axon itself or to its myelin sheath, can lead to what we generally call peripheral neuropathy, basically, nerve damage.
And when we think about movement, there's a specific kind of orchestra involved, isn't there? The motor unit.
Indeed. The motor unit is the fundamental orchestrator of movement. It's quite a system. It starts with a lower motor neuron, whose cell body is sitting in your spinal cord or brainstem. Its long axon then travels out along a peripheral nerve to reach its target muscle. From there, it connects at that neuromuscular junction we mentioned.
Our bridge again.
Right. And finally, it innervates multiple muscle fibers or myofibers. This whole unit, neuron, axon, junction, muscle fibers, works in perfect concert to produce precise muscle contractions.
So that's how we move. But our nerves also give us our sense of touch, temperature, pain. That's the somatic sensory function, right?
Precisely. Somatic sensory function starts with specialized nerve endings, receptors really, in your skin and other tissues. They register specific sensations like pressure, vibration, temperature. From there, the signal travels along sensory nerve fibers back towards the spinal cord, and then usually up to your brain for interpretation. It's this intricate pathway that allows us to feel and make sense of our environment.
And then there are those unsung heroes, the autonomic nerve fibers. Most people probably don't even realize how many of these we actually have.
You're absolutely right. They're often overlooked. Autonomic nerve fibers actually outnumber the somatic ones. They're responsible for all your unconscious bodily functions, things like regulating heart rate, blood pressure, digestion, sweating, breathing, stuff you don't think about.
Right, automatic.
Automatic, exactly. However, symptoms related to their involvement are generally not the primary features of most peripheral neuropathies. There are key exceptions, though, like in diabetic neuropathy, where autonomic problems can be quite significant.
It's amazing how varied these wires are, too, isn't it? In terms of how fast they conduct signals. You called it a symphony of conduction earlier.
Absolutely. The speed and type of signal depend critically on the axon's diameter and how thick its myelin insulation is. For instance, you have thin, unmyelinated fibers. These transmit signals for things like pain and temperature relatively slowly because they lack that thick insulation.
Okay.
In contrast, you have large diameter axons with thick myelin sheaths. These are engineered for speed. They transmit crucial signals for things like light touch, proprioception, knowing where your limbs are, and motor commands. They achieve the fastest possible conduction speeds.
How does the myelin actually speed things up?
Good question. The myelin sheath isn't continuous. It's formed by individual Schwann cells wrapping segments of the axon, leaving tiny gaps called nodes of Ranvier in between. The electrical signal effectively jumps from node to node. It's called saltatory conduction. This is much faster than traveling continuously down an unmyelinated axon. It's a really efficient design. And specific proteins are essential for holding this myelin structure together correctly.
And all these different types of nerve fibers, fast and slow, myelinated and not, are then bundled up for protection, right? Like in a cable.
Yes, exactly like a cable. They're organized by 3 layers of connective tissue. There's the epineurium, which is the tough outer sheath enclosing the entire nerve bundle. Then inside that, the perineurium groups individual axons into smaller bundles called fascicles. And finally, the delicate endoneurium surrounds each individual nerve fiber within those fascicles. This hierarchical structure provides both protection and organization. It's quite robust.
Okay, now that we have a good handle on the normal state, let's talk about what happens when things go wrong. You mentioned there are generally 3 core patterns of peripheral nerve injury.
That's right. Understanding these patterns is key for professionals diagnosing these conditions. The first, and arguably most common, is axonal neuropathies. Here, the axons, the wires themselves, are the primary target of the damage.
Okay, the wire breaks.
Essentially, yes. A classic example, often studied experimentally, is Wallerian degeneration. This happens if you, say, cut a nerve. The part of the axon disconnected from its cell body, the distal part, quickly fragments and breaks down. Its myelin insulation unravels too. Then macrophages, the cleanup crew of the immune system, come in and clear the debris.
Can it repair itself?
It can try. Regeneration starts from the proximal stump, the part still connected to the cell body. A growth cone forms and grows slowly, about 1 millimeter a day, ideally guided back by the remaining Schwann cell tubes. But successful reconnection really depends on the nerve ends being close together.
What happens if it fails?
If regeneration fails or goes awry, you can get something called a traumatic neuroma. This isn't a true tumor, but a painful, disorganized tangle of regenerating axons and Schwann cells.
Ouch. And in real-world neuropathies, it's usually not a clean cut, right?
Exactly. In most clinical axonal neuropathies, the damage happens more slowly, maybe due to toxins or metabolic problems. So you see a mix of degenerating axons and some regenerating ones. Often, the damage just outpaces the body's ability to repair it.
Okay.
A very common presentation is the dying back pattern.
Yeah.
Because the longest axons are the most metabolically demanding and vulnerable, damage often starts at the very ends, like in the toes, and progresses backwards up the leg. This is typical in toxic or metabolic neuropathies.
And electrically, how does this look?
Electrophysiologically, the hallmark of axonal neuropathy is a reduced signal amplitude.
Mm.
The strength of the signal is weaker because fewer axons are working, but the conduction velocity, the speed of the signal in the remaining axons, is often relatively preserved.
Fascinating. Okay, so if axons are one primary target, what about the myelin insulation itself?
That brings us to the second major pattern, demyelinating neuropathies. Here, the primary targets are the Schwann cells, or their myelin sheaths directly, while the axons themselves are relatively spared, at least initially.
So the wire is okay, but the insulation is damaged?
Precisely. The myelin tends to degenerate in a patchy, random, discontinuous way along the nerve. In response, the Schwann cells proliferate and try to remyelinate the axon, but these new myelin segments are often shorter and thinner than the original ones.
And the electrical signature here must be different then.
Completely different. The hallmark of demyelinating neuropathy is a significantly slowed nerve conduction velocity. It makes perfect sense if the insulation is faulty. That rapid saltatory conduction, the jumping signal is disrupted, and the signal slows way down.
Okay, that's clear. Axonal demyelinating. And the third pattern, if neither the axon nor the myelin is the initial target.
That would be a neuronopathy. This occurs when the primary hit is to the neuron cell body itself, located back in the spinal cord ganglia or brainstem.
Ah, right at the source.
Exactly. Since the cell body is the neuron's control center and provides all its metabolic support, its destruction inevitably leads to the secondary degeneration of its entire axon, both proximal and distal parts. Examples include nerve damage from the shingles virus, herpes zoster, or certain chemotherapy drugs like platinum compounds.
And how does this look symptom-wise compared to the dying back pattern?
Because the damage starts at the root, neuronopathies tend to affect both proximal parts of the body, like the trunk or upper limbs, and distal parts, hands and feet, more equally from the outset, unlike the length-dependent dying back axonopathies where the longest nerves suffer first.
Got it. So these different types of injury, axonal demyelinating neuronopathy, also tend to show up in different anatomical patterns of nerve involvement, giving clinicians crucial clues like roadmaps, right?
These clinical patterns are incredibly useful diagnostically. First, you have mononeuropathies. As the name suggests, these affect just a single nerve.
Like carpal tunnel.
Exactly. Carpal tunnel syndrome, affecting the median nerve at the wrist, is the classic example. The symptoms are restricted to that nerve's distribution. Common causes are trauma or entrapment.
Okay. What about multiple nerves?
That brings us to polyneuropathies. These involve multiple nerves, usually in a symmetric fashion. They often start distally and move proximally, beginning in the feet and ascending up the legs, then later maybe the hands. This leads to that classic stocking and glove distribution of sensory loss or tingling.
Right, I've heard of that.
Then interestingly, there's mononeuritis multiplex. This is different. It's characterized by haphazard damage to individual nerves, one at a time, in different parts of the body. So you might develop, say, a right wrist drop and then later a left foot drop. It's asymmetric and patchy.
What causes that usually?
A common cause is vasculitis, where inflammation of blood vessels cuts off blood supply to random nerves.
Ah, okay. And the last pattern?
The last major pattern is polyradicular neuropathies. Here, the problem affects both the nerve roots as they exit the spinal cord and the peripheral nerves further out. This tends to cause more diffuse symmetric symptoms involving both proximal and distal parts of the body. Each of these patterns, mononeuropathy, polyneuropathy, mononeuritis multiplex, polyradicular neuropathy, points towards different potential underlying causes. It's a key part of the diagnostic puzzle.
This is great. Now that we have the types of injury and the patterns down, let's really deep dive into the specific causes of peripheral neuropathies, starting with the inflammatory ones.
Absolutely. Let's begin with a really important one, Guillain-Barré syndrome, often just called GBS. It's technically known as acute inflammatory demyelinating polyneuropathy, or ADP.
Okay.
This is an acute onset, meaning it comes on quickly, immune-mediated demyelinating neuropathy. And it can be quite serious, potentially life-threatening, particularly because it can cause respiratory paralysis.
Wow. How common is it?
Thankfully, it's relatively rare, affecting about one case per 100,000 people annually. Clinically, GBS is characterized by weakness that typically begins in the distal limbs, the feet and legs, and rapidly advances upwards to involve the trunk, arms, and even facial muscles. This is often described as an ascending paralysis.
Ascending paralysis, okay.
Patients also typically lose their deep tendon reflexes quite early on, or flexia. Sensory involvement, like tingling, often occurs, but the weakness is usually the most prominent and concerning feature.
So it's definitely the immune system attacking the nerves somehow.
Precisely. In about 2/3 of cases, GBS onset is preceded, usually by a week or two, by some kind of illness, often a flu-like illness or gastroenteritis. Certain infections are strongly linked, especially Campylobacter jejuni bacteria, often from undercooked poultry, but also viruses like cytomegalovirus or Epstein-Barr virus. Even vaccinations have occasionally been implicated, though that's very rare.
How does the infection trigger it?
The leading theory is molecular mimicry. The immune system mounts a response to the bug, but some part of the bug looks molecularly similar to components of the peripheral nerve, myelin or axon. So the immune system mistakenly attacks the nerves as well.
Friendly fire.
Friendly fire, exactly. It's primarily thought to be a T-cell mediated response, which recruits macrophages, those cleanup cells that then actively strip the myelin sheath away from the axon, particularly near the nodes of Ranvier. Circulating antibodies might also play a role.
And if you looked at the nerve under a microscope,
You'd see inflammation lymphocytes, macrophages, plasma cells infiltrating around small blood vessels and within the nerve tissue itself. And you'd see evidence of segmental demyelination, where chunks of myelin are missing. The damage is often most prominent proximally near the nerve roots.
how is it diagnosed and treated?
Diagnosis relies on the clinical picture, the rapid onset, and ascending pattern. Nerve conduction studies are key. They show that characteristic slowing of conduction velocity typical of demyelination. Interestingly, examining the cerebrospinal fluid, CSF, usually shows a high protein level, but very few inflammatory cells. This is called albuminocytologic dissociation, and it's thought because the inflammation is mainly confined to the nerve roots, which are bathed in CSF.
Treatment.
Treatment focuses on modulating the immune response. Plasmapheresis, which essentially filters the patient's blood to remove harmful antibodies, or intravenous immunoglobulin IVIG therapy, which provides high doses of pooled normal antibodies to suppress the immune attack, can both significantly hasten recovery. Supportive care, especially respiratory support if needed, is critical. Mortality is now down to about 2.5%, but some patients do have residual weakness.
Okay, that's GBS, the acute form. But you mentioned there's also a chronic version?
Yes, that brings us to chronic inflammatory demyelinating polyneuropathy, or CIDP. This is actually the most common chronic acquired inflammatory peripheral neuropathy.
How is it different from GBS?
The key difference is the time course. Unlike the rapid onset of GBS, CIDP is defined by symptoms usually symmetric mixed weakness and sensory loss that persist for more than 2 months. It often evolves over years, sometimes with a relapsing and remitting course, other times just slowly progressive. Some patients might have predominantly sensory issues, others predominantly motor.
And the underlying cause, still immune-related.
Yes, the pathogenesis is thought to be similar to GBS, involving both T cells and antibodies targeting components of the Schwann cell or the myelin sheath. The immune response targets vulnerable spots like the Schwann cell axon junction. Again, macrophages are recruited and strip the myelin.
Does it look different microscopically?
It can, especially over time. Because CIDP is chronic, there's evidence of repeated cycles of demyelination and remyelination attempts by the Schwann cells. This recurrent process leads to excessive Schwann cell proliferation, where multiple layers of Schwann cells wrap around a single axon, forming structures that look like onion bulbs under the microscope. Seeing these onion bulbs on a nerve biopsy is a very characteristic finding in CIDP.
Wow, onion bulbs. That's memorable. How's CIDP treated?
Treatment also focuses on immunosuppression, but usually requires longer-term therapy than GBS. Options include IVI, plasmapheresis, glucocorticoids, steroids, and sometimes other immunosuppressive agents. CIDP is distinguished from GBS clinically by its time course, comorbid versus acute, and often by its response to steroids, which are generally not effective in GBS.
Okay. Beyond GBS and CIDP, inflammatory neuropathies can also pop up with broader systemic autoimmune diseases, right? You mentioned that briefly.
Absolutely. Conditions like rheumatoid arthritis, Sjogren's syndrome, or systemic lupus erythematosus, SLE, can all be associated with peripheral neuropathy, often presenting as a distal sensory or sensory motor polyneuropathy. These are typically distinct from the neuropathies caused by vasculitis.
Right. Tell me more about vasculitis affecting nerves.
Neuropathy associated with vasculitis occurs when non-infectious inflammation of blood vessels, vasculitis, damages peripheral nerves by compromising their blood supply. About a third of patients with systemic vasculitis develop nerve involvement, and sometimes the neuropathy is actually the presenting feature of the vasculitis.
How does it usually present?
It often presents as that mononeuritis multiplex pattern, the haphazard damage to individual nerves. But it can also cause a single mononeuropathy or even a symmetric polyneuropathy. It's commonly seen in specific types of vasculitis, like those associated with MPO-ANCA antibodies or polyarteritis nodosa. Sometimes the vasculitis is localized just to the nerves without systemic involvement.
And the biopsy.
If you biopsy an affected nerve, you'll see patchy axonal degeneration, often worse in some nerve bundles, fascicles, than others. You'll find inflammatory cells clustered around the small blood vessels within the nerve and evidence of damage to the vessel walls themselves. Finding these characteristic blood vessel changes is key to diagnosing vasculitic neuropathy.
Okay, that covers inflammation quite thoroughly. Now let's move on to how infections can directly hijack our nerves.
Infections are another critical category, absolutely. A major one globally, though less common now in developed countries, is leprosy, also known as Hansen disease.
Right.
The bacterium, Mycobacterium leprae, has a unique predilection for invading Schwann cells. In the lepromatous leprosy form, where the cell-mediated immune response is weak, the bacteria proliferate within Schwann cells, leading to segmental demyelination, remyelination attempts, and eventually loss of axons and significant fibrosis within the nerve. This typically causes a symmetric polyneuropathy that's most severe in the cooler distal extremities and face because the bacteria prefer lower temperatures.
And the big danger there is losing sensation.
Exactly. Pain fibers are often prominently involved, leading to loss of sensation. This means patients can easily injure themselves, especially on their hands and feet, without realizing it, leading to chronic, non-healing ulcers and deformities.
Is there another form of leprosy?
Yes, in tuberculoid leprosy, there's a much more active cell-mediated immune response against the bacteria. You see granulomatous collections of inflammatory cells forming in the skin and nerves. This intense inflammation directly injures the nerves in a more localized pattern, leading to significant nerve destruction in the affected areas.
Okay. What about infections more common here, like Lyme disease?
Lyme disease, caused by the Borrelia burgdorferi bacterium transmitted by ticks, can certainly cause neurological problems, usually in its later stages. This can include a polyradiculoneuropathy, affecting nerve roots and nerves, and famously unilateral or even bilateral facial nerve palsies.
Facial palsy, right,
Sure.
and HIV.
IVAIDS is associated with several patterns of peripheral neuropathy, often related to the immune dysregulation caused by the virus, although the exact mechanisms aren't always fully understood. Early on, patients might develop mononeuritis multiplex or cranial nerve problems. Later in the disease, a discal sensory neuropathy, which can be quite painful, is common.
What about diphtheria? I thought that was mainly a throat infection.
It is, but the bacteria, Corynebacterium diphtheria, produces a powerful exotoxin that can cause significant peripheral nerve dysfunction. This results in an acute peripheral neuropathy, often with prominent involvement of the muscles involved in swallowing and breathing, bulbar and respiratory muscles. This can lead to severe disability or death, and it remains a problem in parts of the world with incomplete immunization coverage.
That's serious. And lastly, the varicella-zoster virus, shingles.
Yes, varicella-zoster virus, VZV, the virus that causes chickenpox. After the initial infection, the virus doesn't leave your body. It becomes latent, hiding out in sensory nerve ganglia. Waiting, exactly. Years or decades later, often associated with decreased cell-mediated immunity due to age or illness, the virus can reactivate. It then travels back down the sensory nerve axon to the skin supplied by that nerve, causing the characteristic painful vesicular blistering eruption in a specific dermatome that's shingles.
Usually on the chest or face.
Thoracic and trigeminal nerve distributions are very common, yes. Microscopically, in the affected sensory ganglion, you'd see neuronal death, inflammation, and sometimes bleeding, and there would be axonal degeneration in the corresponding peripheral nerve.
It's incredible how many different bugs target our nerves. Now, let's switch gears again and discuss metabolic, hormonal, and nutritional factors. I know diabetes is a huge one here.
You're absolutely right. Diabetes mellitus is by far the most common cause of peripheral neuropathy worldwide. It's estimated to affect up to 50% of people with diabetes eventually, and maybe 80% of those who've had the disease for over 15 years. It affects both type 1 and type 2 diabetes.
And the most common pattern is?
The most common pattern is an ascending distal symmetric sensorimotor polyneuropathy, that classic stocking and glove distribution again.
What exactly is the high blood sugar doing to the nerves?
It's complex, likely a combination of metabolic and secondary vascular changes. The hyperglycemia itself is toxic. Glucose can non-enzymatically attach to proteins, lipids, and nucleic acids, forming advanced glycosylation end products, or AGs.
AGs.
These AGs interfere with normal protein function and can trigger inflammatory signaling. Also, excess glucose gets shunted into another pathway, producing sorbitol, which can disrupt cellular metabolism and increase osmotic stress within the nerve cells. All these disturbances make the nerves more vulnerable to oxidative stress and damage.
And the blood vessels.
Yes. Diabetes also damages the small blood vessels, the vasa nervorum, that supply the nerves. Things like thickening of the vessel walls and basement membrane changes can lead to reduced blood flow and ischemic nerve damage. So it's a double whammy: direct metabolic toxicity and impaired blood supply.
What does this look like under the microscope?
It's predominantly an axonal neuropathy. You see a reduced number of axons, evidence of myelin breaking down secondary to the axon loss, and sometimes clusters of small, regenerating axons trying to repair the damage. The small blood vessels within the nerve often show characteristic thickening and hyalinization.
And clinically, what do patients experience?
Sensory symptoms are usually prominent early on: numbness, loss of pain sensation, difficulty with balance due to loss of proprioception. Patients might also experience positive sensory symptoms like tingling, paresthesias, or burning pain, dysesthesias. The loss of protective sensation, especially in the feet, carries very high morbidity, leading to unnoticed injuries, foot and ankle fractures, chronic skin ulcers, and potentially amputations.
You mentioned autonomic nerves earlier in relation to diabetes.
Yes, autonomic neuropathy affects a significant minority, maybe 20–40% of diabetes patients, usually alongside the sensorimotor neuropathy. Its manifestations are incredibly varied: postural hypotension, dizziness on standing up, incomplete bladder emptying, leading to urinary problems, sexual dysfunction, gastroparesis, delayed stomach emptying. It can really impact quality of life.
Does diabetes always cause that symmetric pattern?
Usually, but not always. Diabetes can also cause asymmetric presentations like a mononeuropathy affecting a single nerve, cranial neuropathy like a facial palsy, or a painful condition affecting the nerve plexuses in the arm or leg, radicular plexus neuropathy. These might be related more to microvascular disease affecting specific nerves.
Okay, diabetes is clearly a major player. Beyond that, what other metabolic, hormonal, or nutritional issues can cause nerve problems?
There's quite a list. Uremic neuropathy is common in patients with kidney failure. It's typically a distal symmetric neuropathy that might cause muscle cramps or diminished reflexes. It seems to be primarily axonal and often improves somewhat after dialysis begins.
Thyroid issues.
Yes, thyroid dysfunction. Both hypothyroidism, underactive, and hyperthyroidism, overactive, can be associated with neuropathy. Hypothyroidism is often linked to compression neuropathies like carpal tunnel syndrome, possibly due to fluid retention, or a distal symmetric sensory polyneuropathy. Hyperthyroidism, though less common, can sometimes cause a neuropathy resembling GBS.
And vitamin deficiencies.
Absolutely critical. Several vitamin deficiencies are well-known causes. Vitamin B12, cyanocobalamin deficiency, classically causes subacute combined degeneration, affecting both the spinal cord and peripheral nerves. Deficiencies in vitamin B1, thiamine, often seen in alcoholism, vitamin B6, pyridoxine, folate, and even minerals like copper and zinc have all been linked to peripheral neuropathy. It highlights how essential these micronutrients are for nerve health.
Next up, the world of toxic neuropathies. We're definitely exposed to a lot of chemicals in modern life.
Unfortunately, yes. Peripheral nerve damage can certainly result from exposure to various industrial or environmental chemicals, biological toxins, or even therapeutic drugs.
What are some key causes?
Alcohol is a big one, and it seems to have toxic effects on nerves independent of any associated nutritional deficiencies. Heavy metals like lead, mercury, arsenic, and thallium are notorious nerve toxins. Certain organic solvents used in industry can also cause neuropathy.
And medications, especially chemotherapy.
Yes, chemotherapeutic agents are particularly well known for causing nerve damage, which can be a dose-limiting side effect. Drugs like vinca alkaloids and taxanes interfere with microtubules, which are essential for axonal transport, the internal railway system of the nerve cell. Cisplatin, another common chemo drug, can cause a neuronopathy, hitting the nerve cell body itself.
Moving on now to neuropathies associated with malignancy. Cancer seems to impact nerves in so many different ways, not just by physically growing on them.
Indeed. Neuropathies linked to cancer can stem from several distinct mechanisms. The most straightforward is direct infiltration or compression of nerves by the tumor. This is a common cause of mononeuropathy and can sometimes be the very first symptom that leads to a cancer diagnosis. For example, lung apex tumors can compress the brachial plexus, causing arm pain and weakness. Pelvic tumors can affect the obturator nerve, causing leg problems, and tumors near the skull base can cause cranial nerve palsies.
Okay, direct invasion. But you mentioned other ways, like perineoplastic effects.
Yes, the perineoplastic neuropathies are fascinating and complex. Para means alongside, so these occur alongside cancer, but are not caused by direct invasion or metastasis. Instead, they are thought to be immune-mediated.
The immune system attacking nerves again.
Exactly. The body mounts an immune response against the tumor, but sometimes molecules on the tumor cells resemble molecules on nerve cells. This leads the immune system to mistakenly attack the nervous system. These perineoplastic syndromes can actually precede the diagnosis of the cancer itself.
What kind of neuropathies are seen?
The most common pattern is a sensoromotor polyneuropathy, but specific syndromes exist too. For instance, a pure sensory neuronopathy causing severe sensory loss is strongly associated with small cell lung cancer and specific autoantibodies called anti-Hu antibodies. Here, immune cells directly attack the sensory neuron cell bodies in the dorsal root ganglia. Other perineoplastic patterns include syndromes resembling CIDP, plexopathies, or autonomic neuropathy.
Wow. Any other cancer-related nerve issues?
Yes, another important category is neuropathies associated with monoclonal gammopathies. Certain cancers of B lymphocytes, like multiple myeloma or related disorders, involve neoplastic B cells secreting large amounts of a single type of antibody called a monoclonal immunoglobulin or paraprotein.
And these antibodies damage nerves?
Sometimes, yes. The paraprotein itself can be directly toxic to nerves or trigger an immune response against them. For example, IgM paraproteins sometimes bind to a protein called myelin-associated glycoprotein, leading to a demyelinating neuropathy where you can actually see IgM deposits between the myelin layers. IgE or IgA paraproteins can also be involved.
Is POEMS syndrome related to this?
Yes, POEMS syndrome is a distinctive condition characterized by polyneuropathy, organomegaly, enlarged organs, endocrinopathy, monoclonal gammopathy, and skin changes. The neuropathy is often demyelinating and associated with paraprotein deposition. Also, sometimes abnormal B cells produce excessive amounts of immunoglobulin light chains, which can deposit as amyloid fibrils in tissues, including nerves, causing neuropathy either through vascular insufficiency or direct toxicity.
Okay, that's a lot of ways cancer can affect nerves. Let's shift gears to something more physical. Neuropathies caused by physical forces. Everyday trauma and pressure seem like common culprits.
They absolutely are. Peripheral nerves are quite vulnerable to physical injury. Obvious causes include lacerations from sharp objects or bone fragments severing the nerve, or avulsions where tension applied to a limb literally pulls the nerve apart.
But chronic pressure is probably more common day to day.
Much more common. Compression neuropathy, also known as entrapment neuropathy, occurs when a peripheral nerve is chronically subjected to increased pressure within a confined anatomical space or tunnel.
Like carpal tunnel syndrome.
Carpal tunnel syndrome is the absolute classic and the most common entrapment neuropathy by far. It involves compression of the median nerve as it passes through the carpal tunnel at the wrist, beneath the transverse carpal ligament.
Who gets it most often?
It's more common in women and frequently affects both wrists. It's associated with conditions that cause tissue swelling or alter anatomy in the wrist, like pregnancy, inflammatory arthritis, hypothyroidism, amyloidosis, diabetes, or even just repetitive wrist motions.
And the symptoms?
The hallmark symptoms are numbness, tingling, or pain in the thumb, index finger, middle finger, and the radial half of the ring finger, the area supplied by the median nerve. Weakness or atrophy of the thumb muscles can occur later.
Are there other common entrapment sites?
Yes, several. The ulnar nerve is commonly compressed at the elbow in the cubital tunnel, funny bone nerve. The peroneal nerve can be compressed as it wraps around the head of the fibula bone near the knee. This can happen from crossing legs or even prolonged pressure, sometimes called Saturday night palsy, if someone falls asleep with their arm draped awkwardly over a chair back compressing the radial nerve.
What about Morton neuroma? Is that a real tumor?
Morton neuroma is a bit of a misnomer. It's not a true neoplasm or tumor. It's a condition affecting the interdigital nerves in the foot, usually between the third and fourth toes, caused by chronic compression, often from tight footwear. It causes pain in the ball of the foot, called metatarsalgia. Histologically, what you see is extensive perineural fibrosis, thickening of the connective tissue around the nerve, hence it being called a pseudotumor, more common in women.
Okay, we've covered inflammation, infection, metabolic issues, toxins, cancer links, physical forces. Now, finally, for peripheral nerves, let's tackle inherited peripheral neuropathies. These are written into our genetic code.
This is a huge and rapidly expanding area. Inherited peripheral neuropathies are a genetically diverse group of disorders. They often have overlapping clinical phenotypes, meaning different genetic causes can look similar clinically. While some present in childhood, many actually have an adult onset, which can make diagnosis tricky.
So, anyone with unexplained neuropathy might need genetic testing.
It's definitely something clinicians consider, especially if there's a family history, but sometimes even without one, given the possibility of new mutations or variable presentations.
What are the major types?
The major categories include hereditary motor and sensory neuropathies, HMSN, which are much better known as Charcot-Marie-Tooth, CMT disease. Then there are hereditary motor neuropathies, affecting only motor nerves, hereditary sensory neuropathies affecting only sensory nerves, sometimes with autonomic involvement, and other inherited conditions like familial amyloidosis or metabolic diseases that affect nerves.
The genetics must be complicated.
Extremely. The list of genes implicated is continuously growing, impacting all sorts of nerve functions. Myelin proteins, axonal transport, mitochondrial function, transcription factors. There's no single unifying concept.
Let's focus on Charcot-Marie-Tooth disease, since you said it's the most common inherited group.
Good idea. CMT diseases are indeed the most common inherited peripheral neuropathies, affecting roughly 1 in 2,500 people. The classic clinical triad includes progressive distal muscle atrophy, weakness and wasting, especially in the lower legs and feet, leading to characteristic foot deformities like high arches or hammer toes, distal sensory loss, and often reduced or absent reflexes.
And caused by many different genes.
Over 50 different genes now, yes. CMT diseases are broadly classified based on their inheritance pattern, autosomal dominant, autosomal recessive, X-linked, and the primary pattern of nerve injury, whether it's predominantly demyelinating, affecting the myelin sheath, CMT type 1 and others, or axonal, affecting the axon itself, CMT type 2 and others.
Do the demyelinating forms show those onion bulbs?
Yes. Just like in chronic acquired demyelinating neuropathies like CIDP, the recurrent demyelination and remyelination in the inherited demyelinating forms of CMT often leads to Schwann cell hyperplasia and the formation of those characteristic onion bulbs around axons. Sometimes the nerves can even become palpably enlarged because of this.
What are the most common specific types of CMT?
Together, 4 specific genetic types account for over 90% of all CMT cases.
Wow, okay.
The most common by far is CMT1A. It's an autosomal dominant demyelinating form, accounting for over half of genetically defined cases. It's caused by a duplication of the PMP22 gene on chromosome 17, a gene crucial for myelin structure. Patients typically present in their teens or 20s with slowly progressive distal weakness and sensory loss.
Okay, CMT1A. What else?
CMT1B is another autosomal dominant demyelinating type, caused by mutations in the MPZ gene, which codes for myelin protein 0, another key myelin component. Then there's CMTX1, the most common X-linked form, caused by mutations in the GJB1 gene, encoding connexin 32, a protein involved in Schwann cell communication. And finally, CMT2A is the most common axonal form, autosomal dominant, caused by mutations in the MFN2 gene, which is involved in mitochondrial function within the axon. CMT2A often presents earlier and can be more severe than CMT1A.
That's a lot to keep track of. Then there are the hereditary sensory neuropathies where motor function is okay.
That's right. Hereditary sensory neuropathies, HSN, sometimes called hereditary sensory and autonomic neuropathies, HSAN, are a diverse group characterized primarily by loss of sensation. Critically, motor strength is typically preserved.
What's the main problem for patients?
Often, the most significant issue is the loss of pain and temperature sensation. This lack of protective feedback means patients are prone to repeated, unnoticed injuries, especially to their hands and feet, leading to chronic ulcers, infections, and sometimes bone destruction, Charcot joints. These are typically axonal neuropathies.
And familial amyloid polyneuropathies, amyloid depositing in nerves.
Exactly. Familial amyloid polyneuropathies, FAP, are hereditary disorders where abnormal proteins misfold and deposit as amyloid fibrils within peripheral nerves and other organs. The most common cause involves mutations in the gene for transthyretin, TTR. The mutated TTR protein forms amyloid deposits that damage the nerves. Clinically, these often present similarly to the hereditary sensory and autonomic neuropathies.
Okay, we've navigated the complex wiring of the peripheral nerves. Now we cross the bridge literally to the neuromuscular junction, NMJ. This is where the nerve signal gets handed off to the muscle. Let's quickly talk about its structure and how that handoff works.
Absolutely.
Yeah.
The NMJ is an exquisitely specialized structure. It's the interface where the very end of a motor nerve axon meets a skeletal muscle fiber. It's the critical control point for initiating muscle contraction.
So what happens there?
Well, the distal ends of the motor nerves branch into little swellings called synaptic boutons. When the electrical nerve impulse arrives at this terminal, it triggers the release of a chemical messenger, a neurotransmitter called acetylcholine, ATA, into the tiny gap between the nerve and muscle, the synaptic cleft.
Okay.
The muscle cell membrane on the other side, the postsynaptic sarcolemma, isn't flat. It has these intricate infoldings, like little trenches, that increase the surface area. And crucially, these folds are packed with highly localized clusters of ATA receptors.
Receptors waiting for the message.
Exactly. When ATA molecules diffuse across the synaptic cleft and bind to these receptors, it triggers an electrical change in the muscle membrane, initiating the cascade of events that ultimately leads to muscle fiber contraction. It's a very rapid and precise communication system.
And when something goes wrong at this specific communication bridge, what are the general symptoms people experience?
It's quite characteristic. Regardless of the specific underlying cause, whether it's autoimmune, genetic, or toxic, patients with disorders affecting the neuromuscular junction consistently experience painless weakness and, very notably, fatigue.
Fatigue is key.
Yes, typically the weakness worsens with repeated or sustained exertion and often gets progressively worse throughout the day. This fatigability is a really important clinical clue pointing towards an NMJ problem.
Let's dive into the most common causes then. You mentioned they are often antibody-mediated autoimmune. Starting with myasthenia gravis, the name itself, grave weakness, sounds pretty serious.
It does, and historically it was. Myasthenia gravis, MG, is the prototypic autoimmune disease of the NMJ. Autoimmune means the body's own immune system mistakenly attacks healthy tissue.
What is it attacking in MG?
In the vast majority of cases, about 85%, the autoantibodies are directed against the acetylcholine receptors, AChRs, on the muscle side of the junction, the postsynaptic membrane. A smaller subset of patients have antibodies against another key protein involved in clustering these receptors, called muscle-specific receptor tyrosine kinase, or MuSK.
So the antibodies block the receptors.
They do more than just block. The anti-AChR antibodies cause the receptors to be aggregated and degraded more quickly. They can also activate the complement system, a part of the immune system, which directly damages the postsynaptic membrane. The net effect is a significant depletion of functional ACH receptors. So even if the nerve releases normal amounts of AC, there aren't enough working receptors on the muscle side to generate a strong contraction. This leads to weakness.
Okay. And MuSK antibodies.
Anti-MuSK antibodies seem to work a bit differently. They interfere more with the proper trafficking and clustering of the AChRs of the synapse rather than directly destroying them. But the end result is similar: decreased AChR function and impaired neuromuscular transmission.
You mentioned the thymus gland earlier in relation to autoimmune diseases. Is there a connection with MG?
A very strong connection, particularly for patients with anti-AChR antibodies. About 10% of MG patients have a thymoma, which is a tumor of the epithelial cells of the thymus gland. And another 30% or so, especially younger patients, have thymic hyperplasia, where the thymus contains abnormal clusters of B cells forming lymphoid follicles.
Why the thymus?
The thymus normally plays a crucial role in educating T lymphocytes, teaching them to distinguish self from non-self. It's thought that abnormalities in the thymus, the tumor, or the hyperplasia disrupt this normal tolerance process. Interestingly, some muscle-like cells, myoid cells, expressing AChRs, are found in the normal thymus, and it's hypothesized that these might be the source of the antigen that triggers the autoimmunity in MG. Thymic abnormalities are less common in older patients or those with anti-MuSK antibodies.
So how does this actually manifest in patients? What are the key clinical features someone with MG would experience?
The hallmark is fluctuating weakness. It characteristically worsens with exertion and often improves with rest. It also tends to worsen as the day goes on.
Okay, fluctuating and fatigable.
Exactly. A crucial diagnostic clue, and often the presenting symptom, is involvement of the extraocular muscles, the muscles that move the eyes. This commonly causes diplopia, double vision, and ptosis, drooping eyelids. This prominent ocular involvement often helps distinguish MG from primary muscle diseases, where eye muscles are usually spared.
Can it affect other muscles?
Oh yes. Symptoms can remain confined just to the ocular muscles, ocular MG, or they can become generalized, affecting limb muscles, especially proximal ones, making it hard to lift arms or climb stairs, facial muscles, muscles involved in swallowing, bulbar muscles, and even respiratory muscles, Severe weakness of respiratory muscles can lead to a myasthenic crisis, which is a life-threatening emergency requiring mechanical ventilation.
Does it look different in patients with the MuSK antibodies?
Often, yes. Patients with anti-MuSK MG tend to have more focal muscle involvement, sometimes predominantly affecting neck, shoulder, facial, respiratory, or bulbar muscles, and perhaps less prominent ocular symptoms compared to AChR-positive patients.
How is MG diagnosed and treated?
Diagnosis relies on the clinical history, that fluctuating fatigable weakness often with eye signs, physical examination findings, identifying the specific autoantibodies in the blood, anti-AChR or anti-MuSK, and specialized electrophysiologic studies. A key test shows a characteristic decrement or decrease in the muscle's electrical response with repeated nerve stimulation, reflecting the fatigue at the NMJ.
And treatment?
Treatment has several arms. The first line is usually acetylcholinesterase inhibitors. These drugs block the enzyme that normally breaks down HA in the synaptic cleft. By increasing the lifespan of ICI, more of it is available to stimulate the reduced number of receptors, which can improve strength.
Does that fix the underlying problem?
No, it just manages the symptoms. To target the underlying autoimmune attack, treatments include immunosuppressive drugs like glucocorticoids, azathioprine, cyclosporine, or newer agents like rituximab, which aim to decrease the production of the harmful autoantibodies. In acute worsening or crisis, plasmapheresis or IVI can be used for rapid improvement, similar to GBS.
What about the thymus connection? Is removing the thymus helpful?
Thymectomy, surgical removal of the thymus gland, is definitely recommended for patients with a thymoma. Its role in patients without a thymoma, especially those with thymic hyperplasia, is more debated but often considered, particularly in younger patients with a generalized AChR-positive MG, as it can lead to long-term improvement or remission in some. The effectiveness in older patients or those with MuSK antibodies is less clear. With modern treatments, mortality from MG is now less than 5%.
Okay. Now, there's another related condition, Lambert-Eaton myasthenic syndrome, LENS. You mentioned that it seems kind of opposite to MG in some ways.
That's a great way to think about it in terms of the electrophysiology. LEMS is also an autoimmune disorder affecting the NMJ, but the attack here is directed at the presynaptic side, specifically against voltage-gated calcium channels on the motor nerve terminal.
Calcium channels. Why are they important?
These calcium channels are essential for triggering the release of acetylcholine from the nerve ending when the nerve impulse arrives. So in LEMS, the antibodies block these channels, leading to reduced A release.
Ah, so the problem is getting the AC out of the nerve, not the muscle responding to it.
Precisely. And this leads to the key contrast with MG. In LEMS, with rapid repetitive nerve stimulation, calcium levels can build up slightly in the nerve terminal with each pulse, facilitating more AC release. Therefore, the muscle response actually increases or shows an increment with repeated stimulation. Clinically, patients might notice their strength improves briefly after a few seconds of voluntary activity.
Where does the weakness typically show up in LEMS?
It most commonly affects the weakness of the extremities, particularly the proximal leg muscles. Autonomic symptoms like dry mouth can also occur.
And you mentioned a critical association with cancer.
Yes, this is really important. About half of all LEMS cases are paraneoplastic, meaning they are associated with an underlying malignancy. The most common association by far is with small cell lung cancer. In many cases, the neurological symptoms of LEMS actually precede the diagnosis of the cancer, sometimes by months or even years.
So LEMS can be a red flag for lung cancer.
Absolutely. It's thought that the small cell lung cancer cells express the same calcium channel protein that's found on the nerve terminals. The immune system mounts a response against the cancer, but this response cross-reacts with the calcium channels at the NMJ, causing LEMS. So any patient diagnosed with LEMS needs a thorough workup for underlying malignancy, especially lung cancer.
Are there inherited forms of NMJ problems too?
Yes, though they are much rarer. These are known as congenital myasthenic syndromes, CMS. These are not autoimmune. They are genetic disorders, usually autosomal recessive, caused by mutations in genes encoding various proteins essential for NMJ structure or function.
So mutations affecting the nerve side, the gap, or the muscle side?
Exactly. Mutations can affect proteins involved in ACE synthesis or packaging in the nerve terminal, enzymes in the synaptic cleft like acetylcholinesterase, or components of the postsynaptic apparatus like the ACE receptor subunits themselves, or proteins needed for receptor clustering.
How do these present?
They can present anywhere from birth, with severe muscle weakness, poor muscle tone, floppy infant, feeding and breathing difficulties, to milder forms presenting later in childhood or even adulthood. The specific clinical picture, prognosis, and response to treatment really depend on the underlying genetic defect.
Okay, we've covered autoimmune and genetic issues at the NMJ. But you also mentioned disorders caused by toxins can shut down this crucial communication bridge.
Absolutely. The NMJ is a vulnerable target for certain potent toxins. The classic example is botulism.
From contaminated food.
Often, yes, from improperly canned foods containing Clostridium botulinum bacteria. This bacterium produces botulinum toxin, which is one of the most potent neurotoxins known. Its mechanism is to block the release of acetylcholine from the presynaptic nerve terminals.
So, similar to LEMS, but caused by a toxin.
Similar mechanism of blocking AC release, yes, but caused by an external toxin. This leads to flaccid paralysis, which can affect muscles throughout the body, including respiratory muscles, making it life-threatening. Of course, purified forms of botulinum toxin, Botox, are now widely used therapeutically in tiny doses for various medical and cosmetic purposes, precisely because of this muscle-relaxing effect.
Interesting. What about Curar? That sounds like something out of an adventure movie.
It does. Curar is a plant-derived toxin, famously used by indigenous peoples in South America as an arrow poison. It works very differently from botulinum toxin. Curar acts primarily on the postsynaptic side, blocking the acetylcholine receptors.
So more like myasthenia gravis.
In terms of targeting the receptor, yes. By binding to and blocking the AC receptors, Curar prevents AC from activating the muscle, leading to flaccid paralysis. Derivatives of Curar were actually used historically as muscle relaxants during surgery before safer alternatives were developed. These toxins really highlight how critical every step of neuromuscular transmission is.
We've journeyed from the wiring of the peripheral nerves across the communication bridge of the NMJ, and now we arrive at the engine itself, skeletal muscle. Let's quickly review the basic building blocks and how they function before we dive into muscle diseases.
Sounds good. Skeletal muscle is a truly remarkable tissue, responsible for all our voluntary movements. It develops from precursor cells called myoblasts, which fuse together to form long, multinucleated cells called myotubes. These mature into the functional units, the myofibers or muscle fibers. Each myofiber contains thousands of nuclei, typically located just beneath the cell membrane.
And they are organized in bundles.
Yes, myofibers are grouped together into bundles called fascicles. Associated with these fibers are crucial cells called satellite cells. These are essentially tissue stem cells for muscle. They sit quietly until there's an injury, then they activate, proliferate, and fuse with damaged fibers or form new ones, playing a vital role in muscle regeneration.
You mentioned different fiber types earlier, type I and type 2.
That's right. Skeletal muscle isn't uniform. Myofibers are broadly classified into two main types based on their functional and metabolic characteristics. You can visualize these using special stains on a muscle biopsy.
Okay.
Type I fibers are the slow-twitch oxidative fibers. They are built for endurance. They contract relatively slowly, but are highly resistant to fatigue. They rely on aerobic metabolism, so they are rich in mitochondria, the cell's power plants, and myoglobin, which stores oxygen, giving them a red appearance. Think of the muscles used by marathon runners.
Right, endurance. And type 2?
Type 2 fibers are the fast-twitch fibers, built for rapid, powerful movements, but they fatigue more quickly. They rely more on anaerobic glycolysis for energy, so they have fewer mitochondria and less myoglobin, appearing paler, white, or tan. Think of sprinters' muscles. There are also subtypes within type 2, like IA, IS.
And what determines whether a fiber is type I or type 2?
Critically, the fiber type is determined by the innervating motor neuron. All the muscle fibers innervated by a single motor neuron, remember the motor unit, are of the same type. If a muscle fiber loses its nerve supply and gets re-innervated by a neuron of a different type, the fiber can actually switch its type to match the new neuron.
Fascinating. Okay, now a common feature across many muscle disorders is skeletal muscle atrophy, or wasting away. Are there patterns here that give clues, like with nerve damage?
Yes, the pattern of atrophy can be very informative. Atrophy itself, just shrinking of muscle fibers, is nonspecific and can happen from simple disuse, aging, cachexia, wasting associated with chronic illness, or as part of a primary nerve or muscle disease.
But specific patterns point to specific causes.
Exactly. If you see clusters or groups of atrophic fibers all bunched together on a biopsy, that's highly suggestive of a neurogenic process, meaning the nerve supply to that group of fibers has been lost.
Okay, grouped atrophy and nerve problem.
Okay, generally, yes. In contrast, peripheral atrophy, where the muscle fiber atrophy is most pronounced right at the edges of the muscle fascicles, bundles, is a very characteristic feature of dermatomyositis, an inflammatory muscle disease we'll discuss.
Peripheral atrophy equal dermatomyositis. Got it. Any others?
Another pattern is selective atrophy of type 2 fibers, with relative sparing of type I fibers. This can be seen with prolonged corticosteroid therapy or sometimes just with disuse. So yes, the pattern of atrophy provides valuable diagnostic clues.
This brings us to a really important distinction you alluded to. Neurogenic versus myopathic changes in skeletal muscle. It's all about figuring out if the primary problem started in the nerve supplying the muscle or in the muscle fiber itself.
This is absolutely fundamental for diagnosis when looking at a muscle biopsy. Let's look at neurogenic injuries first. As we just discussed, when a muscle loses its nerve supply, innervation, the affected myofibers atrophy. They often take on a flattened, angulated shape.
What happens if the nerve grows back?
If reinnervation occurs, often by sprouting from an adjacent healthy motor axon, the muscle fiber can regain its size and shape. Crucially, if the new nerve is of a different type, say a type 2 neuron reinnervates a type I fiber, the muscle fiber will switch its type to match. Over time, with repeated cycles of denervation and reinnervation, you can end up with large groups of fibers all of the same type, innervated by a single surviving motor neuron. This is called fiber type grouping.
So fiber type grouping is a sign of chronic nerve problems.
Yes, it indicates chronic denervation and reinnervation. And these enlarged motor units, where one nerve is supplying many more fibers than usual, are then vulnerable to widespread atrophy if that single remaining motor neuron gets damaged. That's when you see that grouped atrophy.
Okay, that's the neurogenic picture. Fiber type grouping and grouped atrophy. How does it look different if the problem is primarily within the muscle, a myopathic injury?
Primary myopathic processes look quite different. Instead of group changes, you typically see more random or patchy damage affecting individual muscle fibers. Key features include segmental myofiber degeneration and regeneration.
Segmental, meaning just part of the fiber dies.
Yes, often only a portion of the long muscle fiber undergoes necrosis, death. When this happens, the damaged fiber releases its contents, including enzymes like creatine kinase, CK, into the bloodstream. That's why measuring serum CK levels is such a useful blood test for suspected muscle disease. High levels indicate ongoing muscle fiber damage.
What happens to the dead segment?
Macrophages move in to engulf the debris, a process called myophagocytosis. Meanwhile, those satellite cells we mentioned get activated. They multiply and fuse with the damaged fiber or form new segments, trying to bridge the gap and restore the fiber's continuity. These regenerating fibers have characteristic features on biopsy. They often appear basophilic, bluish with standard H&E stain, and have enlarged prominent nuclei.
So you see both dying and regenerating fibers.
Exactly. In active myopathies, you see a mix of degenerating fibers, myophagocytosis, and regenerating fibers scattered throughout the muscle. However, in many chronic myopathies, the regenerative process eventually fails to keep pace with ongoing damage. This leads to progressive loss of muscle fibers, which get replaced by endomysial fibrosis, scar tissue within the muscle, and fatty replacement.
So the muscle literally gets replaced by scar and fat over time.
Sadly, yes, in many progressive muscle diseases. Other features suggesting a primary myopathy can include myofiber hypertrophy, individual fibers getting abnormally large, perhaps as a compensatory mechanism, and the presence of abnormal cytoplasmic inclusions within the muscle fibers, things like vacuoles, protein aggregates, or clustered organelles, which can be hallmarks of specific types of myopathies.
That distinction is really clear now. Neurogenic equals grouped changes. Myopathic equal random fiber damage, regeneration, eventual fibrosis, and fat. Okay, let's use that framework to delve into specific muscle diseases, starting with the inflammatory myopathies. These are conditions where the muscle is essentially on fire due to an immune system attack.
Right. Historically, this group was dominated by three main entities: dermatomyositis, polymyositis, and inclusion body myositis. However, our understanding has evolved significantly. What used to be broadly lumped under polymyositis is now often recognized as other specific conditions, like immune-mediated necrotizing myopathy or myositis associated with connective tissue diseases.
Let's start with dermatomyositis, DM, then. It often has those distinctive skin features, right?
Exactly. Dermatomyositis is a systemic autoimmune disease characterized by the combination of proximal muscle weakness, difficulty getting up from a chair, climbing stairs, lifting arms, and characteristic skin changes.
What's the immune system attacking here?
In DM, the primary target appears to be the small blood vessels within the muscle, the capillaries. There's evidence of immune complex depositions, particularly the complement membrane attack complex, C5b9, in the capillary beds. This leads to microvascular injury, capillary dropout, and subsequent ischemic damage to the muscle fibers, particularly those at the periphery of the fascicles. There's also evidence for a role of type I interferons in the disease process.
And this vascular damage explains the skin changes, too.
It's thought to be related, yes. You see similar vascular changes like telangiectasias, dilated small vessels, in the nail folds, gums, and eyelids. The characteristic skin rashes are key diagnostic features. The heliotrope rash, which is a lilac or purplish discoloration of the upper eyelids, often accompanied by periorbital edema, swelling around the eyes.
Heliotrope rash, okay.
And Gautron papules, which are scaling, erythematous, reddish patches or bumps over the knuckles, elbows, and knees. Seeing these skin changes along with proximal muscle weakness is highly suggestive of dermatomyositis.
What does the muscle biopsy show?
The muscle biopsy reflects this underlying pathology. You see inflammation, mainly mononuclear cells like lymphocytes and macrophages, but it tends to be concentrated in the perimysial connective tissue around the muscle bundles, and particularly around blood vessels, rather than invading individual muscle fibers extensively. The most characteristic finding is that perivascular atrophy, we mentioned muscle fiber atrophy, and damage that's accentuated at the edges of the fascicles, likely due to the microvascular injury. You might also see degenerating and regenerating fibers scattered about. The inflammatory infiltrate is typically rich in CD4, plus helper T cells and B cells.
Are there specific autoantibodies associated with DM?
Yes, several myositis-specific autoantibodies are associated with dermatomyositis and can correlate with specific clinical features. For example, anti-Me2 antibodies are strongly associated with the classic skin rashes, Gautron papules and heliotrope rash. Anti-Jo1 antibodies are linked to a subset called the antisynthetase syndrome, which includes interstitial lung disease, non-erosive arthritis, and a specific rash on the hands, mechanics hands. Anti-P155, P140 antibodies are more common in paraneoplastic, cancer-associated, and juvenile cases.
Cancer-associated.
Yes, particularly in adults over 40, dermatomyositis carries an increased risk of underlying malignancy. Lung, ovarian, gastrointestinal cancers are common. The DM can be a paraneoplastic manifestation, meaning it's triggered by the cancer, and sometimes improves if the cancer is treated. So adults diagnosed with the DM need screening for underlying cancer. Interestingly, a DM-like picture can also occur as a side effect of certain cancer immunotherapy drugs, checkpoint inhibitors.
Is DM different in children?
Yes. Juvenile dermatomyositis typically presents before age 16. While it shares the muscle weakness and rashes, children are more likely to develop calcinosis, calcium deposits in the skin or muscle, and lipodystrophy, loss of fat tissue. They're less likely to have interstitial lung disease, cardiac involvement, or associated malignancy, and generally have a better prognosis than adults.
Okay, so DM is characterized by vascular injury, perivascular atrophy, and skin rashes. What about the conditions previously called polymyositis? You said that category has changed.
It has. A significant portion of what was historically diagnosed as polymyositis is now thought to fall into two other categories: immune-mediated necrotizing myopathy, IMNM, and myositis associated with other connective tissue diseases. Let's talk about IMNM first.
Okay, IMNM, what is it?
IMNM, sometimes called necrotizing autoimmune myopathy, is another autoimmune condition presenting with subacute muscle weakness, often severe, and usually very high serum creatine kinase levels, indicating significant muscle breakdown.
How is it different from DM or what's left of polymyositis?
The key feature of IMNM on muscle biopsy is prominent myofiber necrosis, death, and regeneration, but typically with minimal or absent inflammatory cell infiltrates. It's like the muscle is being destroyed without a lot of visible immune cells around.
What causes it?
It's associated with specific autoantibodies. One important association is with anti-HMG-CoA reductase antibodies. HMG-CoA reductase is the enzyme targeted by statin drugs. While many patients with these antibodies have been exposed to statins, the condition can occur even without prior statin use, suggesting the statin might trigger autoimmunity in susceptible individuals rather than causing direct toxicity. IMNM is also linked to antibodies against signal recognition particle, SRP.
Okay, so IMNM is mostly muscle death with few inflammatory cells. What about polymyositis EM then? What defines it now?
True, classic polymyositis is now considered a rarer diagnosis, essentially a diagnosis of exclusion. It's defined as an adult-onset inflammatory myopathy, causing symmetric proximal muscle weakness and myalgias similar to dermatomyositis, but crucially lacking the distinctive cutaneous features of DM and also lacking the features of inclusion body myositis.
So weakness without the rash or specific inclusions.
Exactly. And the underlying immune mechanism is thought to be different from DM. In PM, the damage is believed to be mediated primarily by CD8 plus cytotoxic T lymphocytes that directly invade and destroy muscle fibers. Vascular injury doesn't seem to play a major role, unlike in DM.
How does that look on biopsy?
The inflammation in PM is typically endomysial, meaning the inflammatory cells, predominantly CD8 plus T cells, are found within the muscle fascicles surrounding and sometimes invading individual non-necrotic muscle fibers. You also see scattered degenerating, necrotic, and regenerating myofibers in a random or patchy distribution, not concentrated at the fascicle edges like in DM.
Okay, so endomysial inflammation targeting fibers directly. Now, the third major type you mentioned historically, inclusion body myositis, IBM. This one seems quite distinct, especially affecting older adults.
IBM is indeed unique. It's the most common inflammatory myopathy diagnosed in individuals over the age of 65, although it typically begins after age 50.
How does it present clinically?
It causes slowly progressive muscle weakness, but often with a characteristic pattern involving quadriceps muscle weakness leading to falls and weakness of the distal upper extremity muscles, especially finger flexors, making tasks like opening jars or turning keys difficult. Dysphagia, or difficulty swallowing, is also quite common. Creatine kinase levels are usually only modestly elevated, unlike the very high levels often seen in DM or IMNM.
Are there specific antibodies here?
Most of the typical myositis-associated antibodies are absent in IBM. However, an antibody against a protein called cytosolic 5-nucleotidase 1A, CN1A, is found in about half of patients and can be a useful diagnostic marker, though its role in causing the disease isn't clear.
What's the underlying process? Is it purely inflammatory?
That's actually a major point of debate. IBM has features of both inflammation and degeneration. Like polymyositis, the muscle biopsy shows endomysial inflammation with CD8 plus T cells invading muscle fibers. However, IBM also shares features with neurodegenerative diseases like Alzheimer's or ALS.
Oh, so degenerative features.
Yes. The defining features of IBM on biopsy, besides the inflammation, are abnormal cytoplasmic inclusions within the muscle fibers. These include rimmed vacuoles, small vacuoles within the fiber that have distinct granular borders when stained. Electron microscopy reveals characteristic tubulofilamentous inclusions. Furthermore, these inclusions often contain aggregated proteins typically associated with neurodegenerative diseases like beta amyloid and TDP-43. This overlap has led to debate about whether IBM is primarily an inflammatory disease triggering degeneration or a primary degenerative process with secondary inflammation. The fact that purely genetic familial forms of inclusion body myopathy exist without inflammation adds to this complexity.
So biopsy shows inflammation A and D, those rimmed vacuoles and protein aggregates.
Exactly. You see the patchy endomysial inflammation with CD8 plus T cells invading fibers, but also these distinctive degenerative features like rimmed vacuoles and abnormal protein clumps. You also often see significant endomysial fibrosis and fatty replacement reflecting the chronic nature of the disease.
How are these inflammatory myopathies treated? Does treatment differ?
Treatment approaches differ significantly based on the type. Dermatomyositis, polymyositis, and IMNM, being primarily immune-mediated, are typically treated with immunosuppressive agents like corticosteroids, prednisone, often combined with other drugs like azathioprine or methotrexate, or with IVIG. The goal is to dampen the immune attack.
In IBM.
Unfortunately, inclusion body myositis generally responds poorly to conventional immunosuppressive therapies. This lack of response further fuels the debate about its underlying pathogenesis and highlights the need for different therapeutic strategies targeting the degenerative aspects of the disease.
Okay, moving beyond inflammation, our muscles can also suffer from toxic myopathies, problems caused by drugs, toxins, or hormonal imbalances.
This is a really important category, as these are often potentially reversible if the offending agent is identified and stopped. Toxic myopathies can arise from exposure to prescription drugs, recreational drugs, or even hormonal disturbances.
You mentioned statins earlier in relation to IMNM. Can they cause muscle problems directly too?
Yes, absolutely. Statins, the widely used cholesterol-lowering drugs, are probably the leading culprits among prescription medications causing myopathy. This is their most common complication. It typically manifests as muscle pain, myalgia, weakness, or cramps. In most cases, this is thought to be a direct toxic effect on the muscle, distinct from the rarer autoimmune IMNM triggered by statins. The risk seems to depend on the specific statin, the dose, and individual patient factors. Stopping the statin usually resolves the symptoms.
What about other drugs?
Certain antimalarial drugs, like chloroquine and hydroxychloroquine, which are also used to treat autoimmune diseases like lupus and rheumatoid arthritis, can cause a specific type of toxic myopathy. They interfere with lysosomal function within muscle cells, leading to the accumulation of waste products and the formation of vacuoles within the muscle fibers. This causes a slowly progressive weakness.
That sounds quite specific. How does it look on biopsy?
The biopsy shows characteristic vacuolation, predominantly in type I muscle fibers. Ultrastructurally, you see aggregates of whorled, lamellar membranous structures called curvilinear bodies within lysosomes. This drug-induced lysosomal storage myopathy can sometimes also affect heart muscle.
What about muscle problems in the ICU?
Ah, yes, ICU myopathy, sometimes called critical illness myopathy or myosin-deficient myopathy. This is a significant problem in critically ill patients, particularly those receiving high-dose corticosteroids and neuromuscular blocking agents.
Myosin deficient.
Yes, it's characterized by a selective degradation of the thick myosin filaments within the muscle sarcomeres. This leads to profound weakness, which can significantly complicate weaning patients from mechanical ventilation. The exact mechanisms are still being worked out, but likely involve the systemic inflammation and metabolic stress of critical illness, exacerbated by medications.
We touched on thyroid dysfunction earlier with neuropathy. Can it cause myopathy too?
Definitely. Both thyrotoxicosis, hyperthyroidism, and hypothyroidism can affect muscle. Thyrotoxic myopathy often presents as acute or chronic proximal muscle weakness, which can sometimes be the first sign of an overactive thyroid. Hyperthyroidism can also cause exophthalmic ophthalmoplegia affecting the eye muscles. Hypothyroidism, on the other hand, is more typically associated with muscle cramping, aching, slowed movements, and delayed reflexes. Muscle biopsy and hypothyroidism might show some fiber atrophy, glycogen aggregates, and sometimes deposition of mucopolysaccharides.
And alcohol, can it directly harm muscle?
Yes, alcohol can cause several types of muscle problems. Binge drinking can trigger an acute toxic syndrome of rhabdomyolysis, rapid breakdown of skeletal muscle leading to muscle pain, release of myoglobin into the urine, which can damage the kidneys, and potentially acute renal failure. Chronic alcohol abuse can also lead to a slowly progressive proximal muscle weakness.
Okay, a wide range of toxic insults. Now we come to the vast category of inherited diseases of skeletal muscle, where the genetic blueprint itself is faulty. This sounds like a very diverse group.
It truly is. This encompasses a large and diverse collection of disorders where the primary defect lies within the skeletal muscle itself due to inherited genetic mutations. Sometimes the disease is confined mainly to skeletal muscle, but often other organ systems, particularly the heart, are involved as well.
How are they classified? It seems complex.
Historically, they've been subdivided based on various factors. The mode of inheritance, dominant, recessive, X-linked, the pattern of muscle involvement, example, proximal versus distal, the age of onset, the clinical course, progressive versus static, and increasingly by the underlying molecular pathogenesis. But there's definitely overlap between categories.
Let's start with congenital myopathies. The name suggests they are present from birth.
Yes, congenital myopathies typically present in infancy, often with hypotonia, low muscle tone, the floppy infant syndrome, and weakness. A key feature is that they're often relatively static or only slowly progressive, unlike the muscular dystrophies. They are defined by the presence of specific characteristic structural abnormalities within the muscle fibers seen on biopsy.
Can you give some examples?
Sure. Central core disease is usually autosomal dominant, often caused by mutations in the RYR1 gene, encoding a calcium release channel. Biopsies show distinct cores within muscle fibers where mitochondria are absent and the sarcomere structure is disrupted. Nemaline myopathy is named for the presence of tiny rod-like structures, nemaline rods, within the muscle fibers, composed of Z-disc proteins. It can be inherited in dominant or recessive patterns caused by mutations in various genes encoding sarcomeric proteins. Centronuclear myopathy is characterized by muscle fibers where the nuclei are located in the center, resembling immature myotubes instead of at the periphery. It can be X-linked, often severe, caused by MTM1 mutations, or autosomal. Congenital fiber type disproportion is defined by having predominantly small type I fibers and larger type II fibers. Each of these has characteristic histological findings linked to specific genetic causes.
Okay, those are present early and often static. What about the muscular dystrophies? These are generally progressive, right?
Yes, the muscular dystrophies are inherited disorders characterized by progressive muscle damage and degeneration, leading to increasing weakness over time. They typically manifest between childhood and adulthood, although there are also congenital muscular dystrophies that present at birth, but still have a progressive course.
Let's start with the most well-known, the X-linked muscular dystrophies with dystrophin mutation, which includes Duchenne and Becker.
Right. Duchenne muscular dystrophy, DMD, and Becker muscular dystrophy, BMD, are the most common muscular dystrophies overall. DMD affects about 1 in 3,500 live male births and is a severe, relentlessly progressive condition with early onset. BMD is allelic, meaning it's caused by mutations in the same gene, but it has a later onset and a much milder, more slowly progressive phenotype.
They both affect boys primarily because the gene is on the X chromosome.
Exactly. The gene involved is the dystrophin gene, located on the X chromosome. It's actually one of the largest genes in the human genome. Because males have only one X chromosome, a loss-of-function mutation in this gene leads to the disease. Females have two X chromosomes, so they are typically carriers and usually asymptomatic or only mildly affected, though occasionally they can have more significant symptoms due to unfavorable X chromosome inactivation patterns.
What does dystrophin normally do, and why is its absence so devastating in Duchenne?
Dystrophin is a critical structural protein. It's part of a large complex of proteins, the dystrophin glycoprotein complex, or DGC, that links the internal cytoskeleton of the muscle fiber to the extracellular matrix outside the cell membrane.
So it acts like a bridge or shock absorber.
Precisely. It provides mechanical stability to the muscle membrane, sarcolemma, during the stress of muscle contraction and relaxation. Without functional dystrophin, the sarcolemma becomes fragile and easily damaged during muscle activity. This leads to small tears, allowing excessive calcium to leak into the cell, which triggers a cascade of events leading to myofiber degeneration and necrosis. Dystrophin also seems to have roles in cell signaling.
What's the difference between the mutations in Duchenne versus Becker?
It typically comes down to the effect of the mutation on the resulting protein. In DMD, the mutations, often large deletions or duplications or point mutations creating a stop signal, usually cause a disruption of the gene's reading frame. This leads to a complete or near-complete absence of functional dystrophin protein. In BMD, the mutations, often deletions that don't disrupt the reading frame, allow for the production of a truncated but still partially functional dystrophin protein. This residual function explains the milder phenotype.
How does this look on muscle biopsy in Duchenne?
In young boys with DMD, the biopsy shows characteristic features of ongoing muscle damage outpacing repair. You see variation in muscle fiber size, scattered degenerating and regenerating fibers, and eventually progressive replacement of muscle tissue by endomysial fibrosis and fatty infiltration. Inflammation is usually not prominent, except for macrophages cleaning up dead fibers. Immunohistochemical staining for dystrophin is key. It shows a complete absence of dystrophin staining at the sarcolemma in DMD, whereas in BMD, the staining is typically reduced or patchy.
And the clinical course of Duchenne?
Boys with DMD are often normal at birth, but walking may be delayed. Clumsiness and difficulty keeping up with peers become apparent early on. Weakness typically begins in the pelvic girdle muscles, causing a characteristic waddling gait and difficulty climbing stairs. Patients often use their hands to push off their legs to stand up, known as Gower's sign, that extends to the shoulder girdle.
What about the calf muscles? They often look large, right?
Yes, that's the pseudohypertrophy. The calf muscles often appear enlarged, but this is due to the replacement of muscle tissue with fat and connective tissue, not true muscle hypertrophy. Despite the size, the muscles are weak.
How does it progress?
The disease is relentlessly progressive. Wheelchair dependence typically occurs around age 9 to 12. Patients develop joint contractures, scoliosis, curvature of the spine, and progressively worsening respiratory function due to weakness of respiratory muscles. Cardiac involvement is also very common, as dystrophin is present in heart muscle too, leading to cardiomyopathy and arrhythmias, especially in older patients.
Is the brain affected?
Dystrophin is also expressed in the brain, and many boys with DMD have some degree of cognitive impairment or learning disabilities, although the severity varies.
What's the prognosis?
Sadly, without intervention, the mean age of death has historically been in the late teens or early 20s, usually due to respiratory insufficiency or heart failure. With advances in supportive care, particularly respiratory support and cardiac management, life expectancy has significantly improved, now often into the late 20s or early 30s. BMD patients, having some functional dystrophin, have a much slower progression and often a near-normal life expectancy, though cardiac involvement can still be a major issue.
How are they diagnosed and treated?
Diagnosis is usually suspected based on the clinical picture and markedly elevated serum CK levels, often 50 to 100 times normal in the first decade of life in DMD, though they fall later as muscle mass is lost. Definitive diagnosis is made by genetic testing to identify the mutation in the dystrophin gene, or sometimes by muscle biopsy showing absent dystrophin.
Treatment. Is there a cure?
Currently, there's no cure, but treatment focuses on supportive care physical therapy, managing contractures and scoliosis, respiratory support like non-invasive ventilation, and managing cardiac complications. Corticosteroids are often used to slow the progression of weakness for a period. Exciting research is focused on restoring dystrophin expression. This includes strategies like exon skipping using antisense oligonucleotides, drugs that allow the cell's machinery to skip over the mutated part of the gene, producing a shorter but potentially functional dystrophin, similar to Becker, or drugs designed to read through premature stop codons. Gene therapy, aiming to deliver a functional copy of the dystrophin gene, or a smaller functional version, is also under intense investigation, though delivering it effectively to all muscles remains a challenge.
Okay, Duchenne and Becker are the big ones. What about limb-girdle muscular dystrophy, LGMD?
LGMDs are actually a very heterogeneous group of muscular dystrophies, encompassing many distinct genetic entities, currently over 30 known types, both autosomal dominant and recessive. Their unifying clinical feature is weakness that predominantly affects the proximal muscles of the shoulder girdle and pelvic girdle, the limb girdles.
So, difficulty lifting arms and getting up from chairs, similar to inflammatory myopathies.
Similar pattern of weakness, yes, but the underlying cause is genetic, not inflammatory. The age of onset, severity, and rate of progression are highly variable depending on the specific genetic subtype. The causative mutations affect a wide range of proteins involved in various cellular functions, structural components of the muscle fiber, like the sarcoglycans, which are part of that dystrophin complex, enzymes involved in modifying other muscle proteins, proteins of the nuclear envelope, and others. There's no single unifying mechanism for all LGMDs.
Then there's Emery-Dreifuss muscular dystrophy, EMD. What's characteristic here?
EMD is defined by a specific clinical triad. 1. Slowly progressive muscle weakness, often in a humeroperoneal distribution, affecting upper arms and lower legs initially. 2. Significant cardiomyopathy, often with conduction defects, heart rhythm problems that can be life-threatening. And 3. Early development of joint contractures, especially at the elbows, Achilles tendons, and spine.
What causes EMD?
It's caused by mutations in genes encoding proteins of the nuclear envelope, the membrane surrounding the cell nucleus. The most common genes are EMD, encoding emerin, X-linked inheritance, and LMNA, encoding lamins A and C, autosomal dominant inheritance. How defects in these nuclear proteins lead to muscle disease isn't fully understood, but they likely play roles in maintaining nuclear stability during muscle contraction and possibly in regulating gene expression.
How about facioscapulohumeral dystrophy, FSHD? The name suggests specific muscle involvement.
Exactly. FSHD is usually autosomal dominant and is characterized by a very distinctive pattern of weakness that typically starts in the facial muscles, making it hard to smile, whistle, or close eyes tightly, the scapular muscles leading to winging of the shoulder blades, and the humeral upper arm muscles. Weakness can later spread to abdominal and leg muscles.
What's the genetic cause? It sounds complicated.
It is quite complex and still not fully understood. Most cases are linked to changes on chromosome 4 that lead to the inappropriate expression of a gene called DUX4. Normally, DUX4 is silenced in most adult tissues, but in FSHD, it gets turned on in muscle cells. DUX4 encodes a transcription factor, and its abnormal expression likely disrupts the regulation of other genes, leading to muscle damage.
And myotonic dystrophy. We mentioned myotonia earlier, that difficulty relaxing muscles.
Yes. Myotonic dystrophy is the most common form of muscular dystrophy affecting adults. It's an autosomal dominant multisystem disorder. Besides progressive skeletal muscle weakness and myotonia, the cardinal feature, patients often develop cataracts, heart conduction problems, endocrine abnormalities, like insulin resistance or testicular atrophy, and sometimes cognitive issues. There are two main types, DM1 and DM2, caused by mutations in different genes, but DM1 is more common and generally more severe.
What causes the myotonia and other problems in DM1?
DM1 is caused by a fascinating genetic mechanism involving an expansion of CTG triplet repeats in the non-coding region of the DMPK gene. In unaffected individuals, there are a small number of repeats, but in DM1 patients, this number expands significantly, often increasing across generations. Anticipation.
How does the repeat expansion cause disease?
It's thought to be a toxic gain-of-function mechanism at the RNA level. The expanded CEG repeats in the messenger RNA, transcribed from the DMPK gene, form abnormal structures that bind and sequester important RNA-binding proteins, particularly one called muscleblind-like 1, MBNL1.
So the faulty RNA acts like a sponge for essential proteins.
Exactly. By trapping MBNL1 and other proteins, the expanded RNA disrupts their normal function, which includes regulating the splicing processing of many other messenger RNAs. This leads to missplicing of numerous downstream RNA transcripts, including the transcript for a muscle chloride channel called CLC1. Defective CLC1 function is thought to be the primary cause of the myotonia. The misplacing of other transcripts likely contributes to the multisystemic features of the disease.
That's intricate. Lastly, under dystrophies, congenital muscular dystrophies, CMDs. These present early but are progressive, unlike congenital myopathies.
That's the key distinction. CMDs present in infancy, often with severe hypotonia, weakness, and contractures. But unlike the often static congenital myopathies, CMDs typically involve progressive muscle damage. Furthermore, many CMDs are also associated with structural brain abnormalities and eye defects.
What kind of defects cause CMDs?
They fall into several groups based on the affected proteins. One major group involves defects in proteins of the extracellular matrix surrounding muscle fibers, such as collagen 6, causing Ulrich CMD, or laminin alpha-2, also called myosin, causing myosin-deficient CMD. Another large group involves defects in the glycosylation, addition of sugar chains, of a protein called alpha-dystroglycan. Alpha-dystroglycan is a key receptor on the muscle surface that links to the extracellular matrix, and proper glycosylation is essential for its function. Mutations in alpha-dystroglycan itself are usually lethal, but mutations in the various enzymes responsible for its glycosylation cause a spectrum of CMDs, often called dystroglycanopathies.
Why are brain defects common in these types?
Alpha-dystroglycan and its proper glycosylation are also critically important for normal brain and eye development. Therefore, severe defects in this pathway often cause CMD associated with significant CNS malformations, like dysencephaly or cobblestone cortex, intellectual disability, and eye problems. Milder glycosylation defects might cause only skeletal muscle disease, sometimes presenting later as a limb-girdle muscular dystrophy.
Wow, the genetic basis of muscle disease is incredibly diverse. Let's move on to inherited diseases affecting muscle metabolism.
Right, these are diseases of lipid or glycogen metabolism. They are essentially inborn errors of metabolism where a specific enzyme deficiency disrupts the muscle's ability to produce energy from fats or carbohydrates.
How do these typically present?
They often fall into two main clinical patterns. Some present with episodic muscle symptoms triggered by exercise or fasting. This might include severe muscle cramping, pain, myalgia, or even episodes of acute muscle breakdown, rhabdomyolysis, with myoglobinuria, myoglobin in the urine. Others cause slowly progressive muscle weakness without such dramatic episodes.
Can you give examples?
Sure. A common lipid metabolism disorder causing episodic muscle damage with exercise or fasting is carnitine palmitoyltransferase 2, CPT2 deficiency. This enzyme is needed to transport fatty acids into mitochondria for energy production. A classic glycogen storage disease causing exercise intolerance and cramps is myophosphorylase deficiency, McArdle disease, where muscle can't break down glycogen effectively. Acid maltase deficiency, Pompe disease, involves impaired lysosomal breakdown of glycogen. Severe deficiency causes a rapidly fatal infantile form with massive glycogen accumulation in muscle and heart. Milder, later-onset forms cause progressive myopathy, often affecting respiratory muscles, and are now treatable with enzyme replacement therapy.
Now, mitochondrial myopathies. We touched on mitochondria as the cell's power plants. These diseases must affect energy production directly.
Exactly. Mitochondrial diseases are complex, often multisystemic conditions resulting from impaired mitochondrial function, usually leading to deficient ATP generation. Because mitochondria are crucial for energy production, tissues with high energy demands are often most affected.
Like muscle, heart, and brain.
Precisely. Skeletal muscle involvement is common, presenting as weakness, often exercise intolerance, elevated CK levels, or sometimes rhabdomyolysis, cardiac problems, cardiomyopathy, conduction defects, and neurological issues, seizures, stroke-like episodes, developmental delay, hearing loss, optic nerve problems, are also frequent.
Is there a specific clinical clue for mitochondrial myopathy?
One common clue is involvement of the extraocular eye muscles, leading to chronic progressive external ophthalmoplegia, CPEO, a slow progressive paralysis of eye movements, often with ptosis, drooping eyelids. CPEO can occur in isolation or as part of a broader mitochondrial syndrome. Why the eye muscles are so sensitive isn't entirely clear, but they have incredibly high energy requirements.
The genetics must be complex here, too, involving both nuclear and mitochondrial DNA.
Extremely complex. Mitochondria have their own small circular DNA, mtDNA, that encodes some essential proteins and RNAs. But most mitochondrial proteins are encoded by genes in the cell nucleus, nuclear DNA. So mitochondrial diseases can be caused by mutations in either nuclear genes, following Mendelian inheritance patterns, or mtDNA genes, which follow a maternal inheritance pattern, as mitochondria are inherited almost exclusively from the mother's egg.
Maternal inheritance, right?
Yes. And complicating things further, each cell contains thousands of copies of mtDNA. Mutations often affect only a fraction of these copies, heteroplasmy. Disease typically manifests only when the proportion of mutated mtDNA exceeds a certain threshold in critical tissues. This threshold effect contributes to the variable expressivity seen in many mitochondrial diseases.
What does the muscle biopsy show?
The classic morphological finding is the ragged red fiber. This occurs because abnormal mitochondria tend to accumulate, especially under the sarcolemma, muscle cell membrane. These accumulations stain red with the Gamori trichrome stain, giving the fiber edge a ragged appearance. Electron microscopy often reveals structurally abnormal mitochondria with unusual inclusions. Specific enzyme stains can also show defects in mitochondrial respiratory chain complexes. However, some patients with genetically confirmed mitochondrial disease may have nonspecific or even normal muscle biopsies, requiring biochemical or genetic testing for diagnosis.
Are there specific syndromes?
Yes, several clinically defined syndromes are linked to specific mitochondrial defects, although the genotype-phenotype correlation isn't always straightforward. Examples include Kearns-Sayre syndrome, CPEO, retinal degeneration, heart block, often due to large mtDNA deletions, MELIS, mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, often due to a point mutation in an mtDNA to tRNA gene, MRF, myoclonic epilepsy with ragged red fibers, and Leber hereditary optic neuropathy, LHON. Lee syndrome, subacute necrotizing encephalopathy, is genetically heterogeneous, caused by mutations in many different nuclear or mtDNA genes involved in mitochondrial metabolism.
Okay, shifting gears slightly to spinal muscular atrophy, SMA. This is primarily a motor neuron problem, but it manifests as a muscle weakness, right?
Correct. SMA is classified as a neuropathic disorder because the primary pathology is the progressive loss of lower motor neurons in the spinal cord and brainstem. However, this loss of motor neurons leads directly to denervation and subsequent weakness and atrophy of skeletal muscles.
Is this a common cause of the floppy infant syndrome?
Yes, severe forms of SMA are a leading genetic cause of infant mortality and hypotonia. SMA represents the prototypic neuronopathy affecting infants and children, contrasting with primary muscle diseases like congenital myopathies or dystrophies that can also cause floppiness.
What's the genetic cause of SMA?
It's an autosomal recessive disorder caused by loss-of-function mutations in the SMN1, survival of motor neuron 1, gene on chromosome 5. Humans have a nearly identical copy gene called SMN2, but due to a subtle difference, SMN2 mostly produces a less stable, less functional SMN protein. The severity of SMA often correlates inversely with the number of SMN2 copies. A person has more copies usually means a milder phenotype because some functional protein is still made.
What does SMN protein do?
Its exact functions are still being fully elucidated, but it plays critical roles in RNA processing, particularly the assembly of spliceosomes, which are essential for proper gene splicing. Why motor neurons are so uniquely vulnerable to its deficiency is a key area of research. The deficiency leads to progressive motor neuron death.
And the muscle biopsy reflects this nerve loss.
Yes. The muscle biopsy in SMA shows the classic features of denervation atrophy. You typically see large fields or zones containing severely atrophic myofibers, both type I and type II, often described as panfascicular atrophy. Scattered amongst these atrophic fibers are remaining normal-sized or even hypertrophied fibers, usually type Y, which have retained their innervation. This pattern of large groups of uniformly atrophic fibers is characteristic of SMA. Importantly, revolutionary treatments targeting SMN protein levels are now available for SMA.
Finally, for inherited muscle diseases, let's cover ion channel myopathies, or channelopathies. This sounds like problems with the electrical gates in the muscle membrane.
That's a perfect way to describe them. Channelopathies are inherited diseases caused by mutations in genes encoding ion channel proteins, the pores, or gates that control the flow of ions, like sodium, potassium, calcium, and chloride across the muscle cell membrane. This ion flow is essential for generating and regulating the electrical signals that trigger muscle contraction.
How do they usually present?
Mutations affecting these channels can lead to either decreased muscle excitability, causing episodes of weakness or paralysis, or increased excitability, causing muscle stiffness or myotonia. The specific symptoms depend on which channel is affected and how the mutation alters its function. Many are autosomal dominant with variable penetrance.
Can you get some examples?
Sure. Mutations in sodium channel genes, SCN4A, can cause various disorders ranging from myotonia to different forms of periodic paralysis, episodes of temporary weakness or paralysis. Periodic paralysis is often classified based on serum potassium levels during attacks, hyperkalemic, hypokalemic, or normokalemic. Mutations in a muscle calcium channel subunit gene, CLCA1S, are the most common cause of hypokalemic periodic paralysis. Mutations in the main muscle chloride channel gene, CLC1, cause myotonia congenita, inherited muscle stiffness without weakness. And mutations in the potassium channel gene, KCNJ2, cause Anderson-Towel syndrome, featuring periodic paralysis, cardiac arrhythmias, and skeletal abnormalities.
What about the ryanodine receptor? Isn't that linked to malignant hyperthermia?
Yes, absolutely. The ryanodine receptor, RYR1, is not on the surface membrane, but it's a crucial calcium release channel located on the sarcoplasmic reticulum, the internal calcium store within muscle cells. Mutations in RYR1 are linked to certain congenital myopathies like central cord disease, but also, very importantly, to malignant hyperthermia, MH.
What is malignant hyperthermia?
MH is a potentially fatal pharmacogenetic disorder. Individuals with susceptible RYR1 mutations, or sometimes mutations in CACNA1S, can experience a hypermetabolic crisis when exposed to certain triggering agents, primarily volatile inhalational anesthetics like halothane, sevoflurane, and the muscle relaxant succinylcholine.
What happens during a crisis?
The mutated receptor causes an uncontrolled excessive release of calcium from the sarcoplasmic reticulum into the muscle cell cytoplasm. This massive calcium overload triggers sustained muscle contraction and rigidity, leading to a hypermetabolic state with rapid heart rate, tachycardia, rapid breathing, tachypnea, muscle spasms, a dramatic rise in body temperature, hyperpyrexia, and metabolic acidosis. It's a medical emergency requiring immediate cessation of the triggering agent and administration of a specific antidote, dantrolene.
Okay, we've covered an incredible amount of ground today, exploring diseases affecting the nerves, the neuromuscular junction, and the muscles themselves. But sometimes the problem isn't a degenerative or inflammatory process. It's an abnormal growth, a tumor.
Duh.
Let's finish by talking about peripheral nerve sheath tumors.
Right. These are tumors arising from the cells that normally form the supportive sheaths around peripheral nerve fibers. The vast majority of these, whether benign or malignant, show features of Schwann cell differentiation, those cells that make myelin and support axons.
What are the main types?
The three most common and important types are schwannoma, neurofibroma, and the malignant counterpart, malignant peripheral nerve sheath tumor, MPNST. There are also rarer tumors arising from perennial cells. These tumors can arise anywhere along the course of peripheral nerves, from the nerve roots within the spinal canal or skull base, out to the smallest nerve branches in the skin or soft tissues.
You mentioned earlier these tumors have some unique features compared to other soft tissue tumors.
Yes, a couple of things really stand out. Firstly, there's a remarkably strong association between these tumors and specific inherited familial tumor syndromes, particularly neurofibromatosis type 1, NF1, and neurofibromatosis type 2, NF2, and also a related condition called schwannomatosis. Secondly, and this is quite unusual for most sarcomas, malignant soft tissue tumors, MPNSTs, especially when they occur in NF1 patients, often arise through the malignant transformation of a pre-existing benign nerve sheath tumor, specifically a type of neurofibroma called a plexiform neurofibroma. This progression from benign to malignant is more typical of carcinomas, like colon cancer arising from polyps.
Interesting. Let's start with schwannomas. Are these generally benign?
Yes, schwannomas are almost always benign tumors composed purely of differentiated Schwann cells. They often arise directly from a peripheral nerve.
Are they linked to those genetic syndromes?
Yes, schwannomas are a key component of NF2. Patients with NF2 typically develop multiple schwannomas, classically bilateral vestibular schwannomas on the hearing balance nerves. Even sporadic schwannomas occurring in people without NF2 are very frequently associated with inactivating mutations in the NF2 gene, which is located on chromosome 22. Loss of the protein product of this gene, called merlin or schwannomin, seems to be a critical step in their development.
What does merlin normally do?
Merlin is a cytoskeletal protein that plays a role in regulating cell shape, growth, and adhesion by interacting with various signaling pathways. Loss of its function allows Schwann cells to proliferate abnormally.
What do schwannomas look like?
Grossly, they are typically well-circumscribed, encapsulated masses. They often arise eccentrically from a nerve, meaning they are attached to the nerve but tend to displace the main nerve trunk rather than infiltrating it. This encapsulation often allows them to be surgically shelled out or resected without sacrificing the entire nerve, which is a key difference from neurofibromas. They usually appear as firm, gray masses.
And under the microscope?
Microscopically, schwannomas classically show a mixture of two patterns: dense cellular areas called Antoni A areas, and looser, less cellular areas called Antoni B areas.
Antoni A and B.
Okay. Antoni A areas are composed of spindle-shaped Schwann cells arranged in intersecting bundles or fascicles. A very characteristic feature within Antoni A areas is nuclear palisading, where the nuclei line up in rows. Sometimes these palisading nuclei surround central nuclear-free zones composed of cell processes, forming structures called Verroque bodies. Antoni B areas are hypocellular, with the spindle cells spread further apart in a loose, myxoid, gelatinous extracellular matrix, often with small cyst formation.
How do you confirm they are Schwann cells?
The tumor cells typically have elongated nuclei that are often wavy or buckled in shape. Electron microscopy shows individual cells wrapped in basement membrane material. Critically, schwannomas are almost uniformly and strongly positive for the immunohistochemical marker S100, which confirms their Schwann cell origin. Axons are generally excluded from the main tumor mass, being pushed aside.
Can they look worrying sometimes?
Yes. Degenerative changes are common in schwannomas, including nuclear atypia, variation in size and shape, cystic changes, thick-walled blood vessels, and sometimes even areas of necrosis. These degenerative features, especially nuclear atypia in large or mitotically active schwannomas, can sometimes mimic malignancy, sarcoma, but true malignant transformation of a schwannoma is exceptionally rare.
Where do they commonly occur?
As mentioned, they often cause symptoms by local compression of the nerve they rise from or adjacent structures. Within the skull, the most common site by far is the cerebellopontine angle, where they typically arise from the vestibular branch of the 8th cranial nerve. These cause tinnitus, ringing in the ear, and hearing loss, and are often called acoustic neuromas, although that's a misnomer, since they arise from the vestibular balance nerve, not the acoustic hearing nerve, and they are schwannomas, not neuromas.
Okay. Where else?
Elsewhere within the dura, the covering of the brain and spinal cord, they tend to arise preferentially from sensory nerves, like branches of the trigeminal nerve or the dorsal sensory nerve roots of the spinal cord. Outside the dura, they can occur along any peripheral nerve trunk or present as soft tissue masses without an obvious nerve connection. Surgical removal is usually curative.
Okay, so schwannomas are benign, encapsulated, S100 positive, linked to NF2, and rarely malignant. Now, what about neurofibromas? You said they are more complex?
Neurofibromas are also benign nerve sheath tumors, but they have a more heterogeneous composition compared to schwannomas. While the neoplastic cell is still the Schwann cell, neurofibromas contain a significant admixture of other cell types normally found in a nerve fascicle, including perineural-like cells, fibroblasts, mast cells, and specialized CD34-positive spindle cells. The axons themselves are typically incorporated within the tumor mass, not just displaced like in schwannomas.
Are they linked to NF1?
Yes, neurofibromas are the hallmark lesion of neurofibromatosis type 1 NF1. They can also occur sporadically in individuals without NF1.
What's the genetic basis?
In neurofibromas, particularly those associated with NF1, it's the Schwann cells within the tumor that show complete loss, biallelic inactivation, of the NF1 gene product, neurofibromin. Neurofibromin acts as a tumor suppressor by inhibiting the activity of a key growth signaling pathway involving RAS. Loss of neurofibromin leads to hyperactive RAS signaling, promoting Schwann cell proliferation. Interestingly, the other non-neoplastic cells within the neurofibroma usually still have one functional copy of the NF1 gene, haploinsufficiency, but this might make them behave abnormally. Mast cells might secrete growth factors that further stimulate the neoplastic Schwann cells, contributing to tumor development. That's complex interplay.
Are there different types of neurofibromas?
Yes, they are typically classified based on their growth pattern and location. 1. Superficial cutaneous neurofibromas. These present as soft, fleshy, often pedunculated, stalk-like nodules on the skin. They can occur as isolated lesions, sporadic, or be very numerous in patients with NF1. Microscopically, they are usually well-delineated but unencapsulated masses in the dermis, composed of loosely arranged spindle cells, Schwann cells and others, and a fine collagenous stroma. 2. Diffuse neurofibromas. These typically present as large, plaque-like elevations of the skin, often associated with NF1. Microscopically, they show an infiltrative growth pattern within the dermis and subcutaneous tissue, entrapping normal structures like fat and skin appendages. They can grow quite large. 3. Plexiform neurofibromas. These are distinct and clinically significant. They can occur in deep locations or superficially, but they characteristically involve multiple fascicles of a nerve trunk or nerve plexus, growing within and expanding the nerve bundles, often described as feeling like a bag of worms. These are considered pathognomonic for NF1, meaning their presence essentially diagnoses NF1. Microscopically, they show expansion of nerve fascicles by the heterogeneous neurofibroma cell population, entrapping residual axons. The extracellular matrix can vary from loose and myxoid to more collagenous, sometimes with characteristic bundles of collagen described as resembling shredded carrots.
And these plexiform ones are the ones that can become malignant.
Exactly. The risk of malignant transformation into an MPNST is primarily associated with plexiform neurofibromas. It can sometimes occur in diffuse neurofibromas too, but is rare in the typical cutaneous type. The overall lifetime risk of developing an MPNST for a patient with NF1 is estimated to be around 5–10%, significantly higher than in the general population. The risk seems higher in patients with a large burden of plexiform neurofibromas.
So those are the benign nerve sheath tumors. What happens when they do turn malignant, becoming malignant peripheral nerve sheath tumors, MPNSTs?
MPNSTs are sarcomas arising from peripheral nerves or from pre-existing neurofibromas showing Schwann cell differentiation. Most are high-grade aggressive tumors, though lower-grade variants exist.
Where do they typically arise?
As mentioned, about half arise in patients with NF1, presumed to develop from malignant transformation of a plexiform neurofibroma. The other half occur sporadically, arising de novo from a nerve or soft tissue. They tend to affect larger peripheral nerves, often located deep in the chest, abdomen, pelvis, neck, or limb girdles.
What drives the transformation to malignancy?
The molecular genetics are complex, involving multiple chromosomal aberrations and mutations in various tumor suppressor genes and oncogenes, often building upon the initial loss of NF1 and the NF1-associated cases. The exact molecular pathways driving transformation are still being actively researched.
What do they look like pathologically?
MPNSTs are typically poorly defined tumor masses that often infiltrate along the axis of the parent nerve and invade adjacent soft tissues. Microscopically, their appearance can vary widely. Typical cases show malignant spindle cells arranged in fascicles, often with variable cellularity giving a marbleized appearance. Mitotic figures, signs of cell division, necrosis, cell death, and nuclear anaplasia, abnormal cell appearance, are usually prominent in high-grade tumors.
Can they look like other things?
Yes, some MPNSTs show divergent differentiation, meaning they contain focal areas that differentiate along other lines, such as glandular, epithelioid, cartilaginous, chondroid, osseous bone-forming, or even skeletal muscle, rhabdomyoblastic, morphology. An MPNST with rhabdomyoblastic differentiation is specifically called a Triton tumor. Distinguishing MPNST from other high-grade spindle cell sarcomas can sometimes be challenging based purely on histology. Clues like a clinical diagnosis of NF1, a clear anatomic relationship to a large nerve, or origin within a pre-existing neurofibroma are very helpful. S100 positivity is variable in MPNSTs, often weaker and patchier than in benign schwannomas or neurofibromas.
Okay, let's finish by tying these tumors back to the overarching systemic syndromes. Neurofibromatosis type 1, NF1, and type 2, NF2. Remind us of the key features.
Absolutely, these are critical to understand. Neurofibromatosis type 1, NF1, is a relatively common autosomal dominant disorder, affecting about 1 in 3,000 individuals. It's caused by loss-of-function mutations in the NF1 gene on chromosome 17, which encodes the tumor suppressor neurofibromin. As we discussed, neurofibromin normally restrains RAS signaling, so its absence leads to uncontrolled cell growth.
What are the main clinical features of NF1?
NF1 has very high penetrance, most people with the mutation show signs, but highly variable expressivity. The severity and specific features vary greatly. Key features include non-neoplastic manifestations, multiple café au lait spots, those flat light brown skin macules, axillary or inguinal freckling, Lisch nodules, pigmented hamartomas of the iris, skeletal defects like scoliosis or bowing of long bones, and often learning disabilities or intellectual disability. Tumors, a greatly increased risk of developing neurofibromas, cutaneous, diffuse, and especially plexiform, MPNSTs, optic nerve gliomas, tumors of the nerve connecting the eye to the brain, common in childhood, other glial tumors of the brain, and pheochromocytomas, tumors of the adrenal gland.
So a very wide range of potential problems.
Yes, it's a truly multi-system disorder. Severity can range from very mild, perhaps only café au lait spots, to severe with disfiguring plexiform neurofibromas, malignant tumors, and significant neurological or skeletal complications.
And neurofibromatosis type 2, NF2. Less common, different gene, different tumors?
Exactly. NF2 is much less common than NF1, affecting about 1 in 40,000 to 50,000 people. It's also autosomal dominant, caused by mutations in the NF2 gene on chromosome 22, which encodes the protein myelin. Remember, myelin is also frequently mutated in sporadic schwannomas and meningiomas.
And myelin's role again?
Myelin is also thought to act as a tumor suppressor, involved in regulating cell shape, growth, and adhesion through cytoskeletal interactions and signaling pathways. Loss of Merlin function leads to the development of specific types of tumors.
What are the hallmark tumors of NF2?
The defining feature of NF2 is the development of bilateral vestibular schwannomas affecting the 8th cranial nerve on both sides. This typically leads to progressive hearing loss, tinnitus, and balance problems, usually starting in late adolescence or early adulthood. Patients with NF2 are also highly predisposed to developing multiple meningiomas, tumors arising from the meninges, the coverings of the brain and spinal cord ependymomas, tumors arising from the lining of the central canal of the spinal cord. Cutaneous schwannomas can occur, but neurofibromas and café au lait spots are generally not features of NF2.
Are there other non-tumor features in NF2?
Yes, patients can also develop other lesions like cataracts at a young age, or non-neoplastic growths within the nervous system like schwannosis, nodular ingrowths of Schwann cells into the spinal cord, or glial hamartia, microscopic collections of glial cells in abnormal locations. The clinical picture is dominated by the progressive neurological problems caused by the multiple tumors, especially the bilateral vestibular schwannomas. #tag outtrack2. So if we try to connect all of this back to the bigger picture, what really stands out, I think, is the incredible anatomical precision with which these diseases target our bodies. Whether it's the delicate insulation of a single nerve fiber in GBS, the microscopic communication gap in myasthenia gravis, or the very contractile fabric of our muscles in a dystrophy. It's quite amazing.
Yeah, the specificity is striking.
And it highlights not just the vulnerability of these systems, but also how often these seemingly isolated issues, weakness in one arm, maybe some odd sensations, can actually point towards much broader systemic conditions, sometimes even an underlying cancer, as we saw with LEMS or dermatomyositis, or these complex genetic predispositions like NF1 or CMT.
Right, and here's where it gets really interesting for me. What this whole deep dive reveals isn't just the sheer volume of knowledge involved, but how our understanding is constantly evolving. From visualizing those onion bulb formations in CIDP as signs of chronic repair, to recognizing the shredded carrot collagen in plexiform neurofibromas, or seeing those ragged red fibers telling a story about mitochondrial energy failure. These microscopic details, these specific patterns we've talked about, they're as fascinating as they are critical for diagnosis and understanding. So what does this all mean for you listening?
Well, it's about empowering you at this comprehensive perspective, helping you appreciate that seemingly similar symptoms can have vastly different, incredibly intricate causes right down at the cellular and genetic level. It's about gaining that deeper insight, the kind that elite professionals in this field use every day.
And that really raises an important question for all of us, doesn't it? Given the rapidly advancing genetic and immunologic insights we've explored today, from autoantibodies to gene mutations to toxic RNA, how might our diagnostic approaches, and more importantly, our therapeutic strategies for these complex neuromuscular disorders continue to be revolutionized in the next, say, 5 or 10 years?
Yeah, what's next?
What new aha moments are just around the corner? What breakthroughs will fundamentally change how we understand and treat these often devastating conditions? It feels like the journey of understanding here is really far from over.